Welcome, my name is Dimitris Karavias and I'm a locum HPB consultant in the University Hospital of Southampton. This is a brief overview of Gallstone disease, and the presentation was made possible with the invaluable help of Arjun Takar, a consultant HPB surgeon and senior lecturer at the University Hospital of Southampton. Hopefully, by the end of the presentation, you will have learned the common types of gallstones. You will be able to identify the symptoms of gallstone disease. We will also discuss anatomy and pathophysiology, the differential diagnosis, complications and the management of gallstone disease, and briefly at the end we will go through the NICE guidelines. There are two definitions that we should be familiar. One is choledocholithiasis, which is the presence of gallstones in the gallbladder. However, a second term that usually confuses students is choledocholithiasis, which is the presence of gallstones within the biliary tree. The incidence of gallstones is estimated roughly around 10 to 15% of the population. Most patients are asymptomatic, and the incidence tends to increase with age, and gallstone disease is more frequent over the age of 40. Females tend to develop problems from gallstones more frequently, and also there is a considerable geographical variation. Gallstone disease is the most common GI surgical cause for hospital admission. The gallbladder sits in the right upper quadrant in the posterior aspect of the liver and is connected to the biliary tree through a small duct called the cystic duct. Next to the cystic duct, usually there is the blood supply of the gallbladder called the cystic artery, which most of the times originates from the right hepatic artery. However, the anatomical variance is great. There are several different types of gallstones. The most common ones are cholesterol or mixed stones that contain calcium, and for that reason they are radiopaque. However, there are also pigmented stones, either black stones, which tend to be small. They are made of calcium bilirubinate and mucin glycoproteins and associated with hemolytic conditions, or brown stones, which are more common in Asian populations, and they are associated with infections like parasitic or bacterial infections, and also these types of stones can develop within the biliary tree along with the gallbladder. There are several risk factors. The most common one, as we said, is age. Females also tend to develop gallstones twice as frequently, and it's quite a significant problem during pregnancy. The prevalence of gallstones is more common in North America and Europe, and we suspect it's due to dietary factors that lead to obesity, due to diet high in fats and cholesterol, and a lot of the times rapid weight loss can also lead to the development of gallstones. However, there are several genetic predispositions and hereditary diseases. Family history is something quite significant, most likely due to similar dietary factors, but also in diseases like celiac disease, Crohn's disease, in cirrhosis, in patients with cystic fibrosis, and very common in patients with hemolytic diseases like spherocytosis, sickle cell disease, or porphyrias. However, there are several drugs also that can increase the risk of developing gallstones. We know that patients on long-term parenteral nutrition are in higher risk in developing gallstones. Patients on octreotide can also have problems due to gallstones, and also antibiotics like ceftriaxone can increase the risk. Some diuretics like the thiazide diuretics, fibrinogens, which is essentially treatments for high triglycerides, and the weight loss medication Orlistat, and also there are some reports saying that proton pump inhibitors can increase the risks. However, There are some reports that say that statins and ursodeoxycholic acid may decrease the overall risk of developing gallstones. Since the 1950s, we have been using stereotypic mnemonics to describe gallstone disease, and the most commonly one used is the 5 F's of gallstone disease. I'm sure you're all familiar with the term of female, fertile, far, fair, and 40. And also recently we have been using the obesity as a risk factor. However, given the diversity, we shouldn't be using these terms anymore. As we said, most patients are asymptomatic. However, 2 to 4% of patients will develop symptoms each year. Once symptomatic, patients tend to have recurrent problems, and although this is an unpredictable time frame, a simple rule is that patients tend to have 1 to 2% annual and additive risk. So someone who has symptomatic gallstone disease essentially has 2% of having recurrent problems this year, 4% next year, 16% the year after, etc., etc. So that's why we tend to advise patients with symptomatic gallstone disease to at least consider having the gallbladder removed. Imaging, essentially every imaging modality can help us with the diagnosis of gallstone disease. However, the simplest and more accessible one is the use of an ultrasound scan. It can give us amazing views both of the abdominal wall and the liver, but typically we can see the gallbladder, gallstones, and also sludge or grit. The radiologists usually comment that they can see a mobile stone with acoustic shadow, which is essentially diagnostic. However, as we discussed earlier, because most of the stones are cholesterol stones and contain a lot of calcium, they can be radiopaque. So in patients with big gallstones, we might be able to see it in a simple abdominal X-ray. So the role of CT scan and an MRI is questionable. However, due to accessibility, a lot of patients tend to get a CT scan in admission, which can give us good views of the gallbladder and the gallstones. It's not the ideal modality, but can help for patients that have cholecystitis. And of course, the MRI scan can give us amazing and very detailed views of the biliary tree and can help us distinguish whether we have stones within the common bile duct and whether the patients need further investigation or intervention to clear the biliary tree. So, presentation. Most patients present with biliary colic. However, some can present with an infection called an acute cholecystitis. Sometimes if we have gallstones that are dislodged from the gallbladder, patients can develop gallstone pancreatitis. If the stones block the common bile duct, then the patients can present with Choledocholithiasis and jaundice. If there is an infection due to the gallstones into the biliary tree, then we can have cholangitis. Sometimes, especially with older patients, when we have big stones that are impacted in the fundus of the gallbladder, they can chronically press either the common bile duct or the bowel, and if you have recurrent infections, then you can get a fistula between the gallbladder and the bowel where the stones can pass through, and that can cause gallstone ileus. And there are some reports saying that gallstones can be related to gallbladder cancer. So, the main problem is that most of the patients will present with either epigastric pain, epigastric discomfort, or right upper quadrant pain. And as you can imagine, there are several other conditions that can cause similar problems. The most common one is pancreatitis. A heart attack can also mimic the same symptoms. A patient presenting with a perforated peptic or duodenal ulcer can also have the same problems as patients with pneumonia Someone who would present with right base pneumonia, for example, can have exactly the same symptoms. Patients with gastritis, sometimes patients with appendicitis, or patients with renal colics and stones. Similar symptoms can be quite commonly described by patients that have hiatal hernias or cholangitis, and also patients presenting with liver abscess or hepatitis. So, as we discussed, the most common presentation is a biliary colic. It's essentially an epigastric or right upper quadrant pain, usually after a fatty meal, and the typical scenario is a patient coming late at night after a takeaway with excruciating pain. Usually the symptoms are transient and they can last from half an hour to usually up to 2 hours, and they can be alleviated with normal pain relief most of the times. However, the pain can be from mild to excruciating. A lot of patients have accompanied nausea and vomiting, and also they can complain about intolerance to heavy or fatty foods. They can say they might have a metallic taste in their mouth or feel quite bloated. Choledocholithiasis, on the other hand, which is, as we said, gallstones in the biliary tree, can present in 10 to 20% of the patients, and although most of the cases are asymptomatic, a lot of patients presents with either deranged liver function tests or with jaundice if the stone essentially is blocking the outflow of the liver. The two most common problems with choledocholithiasis is that patients can develop pancreatitis or also cholangitis. The imaging modality that will help the most is an MRCP, like in the image you see, and then essentially we would need to clear the biliary tree either with an endoscopic procedure, ideally, or if that's not possible for many reasons, we can always do it surgically with the CPD exploration. Cholangitis is the acute inflammation and infection within the biliary tree, and most commonly it is caused due to increased pressure into the bile duct. It is a medical emergency with up to 10% mortality, and although we previously believed that essentially the pathogens and bacteria travel through the bile and the bowel, now we know that most likely it is due to ascending infections that spread hematogens along the blood supply of the common bile duct. As we said, because this is a medical emergency, we need to diagnose these patients quite early, and we need to resuscitate them with aggressive fluid resuscitation and antibiotics, and if there is a blockage to the common bile duct, then we need to decompress the system with an urgent endoscopic procedure. There are different symptoms, however the most important that you should know is the Charcot's triad, where the patient presents with right upper quadrant pain, with fevers and rigors and jaundice, and if they also have altered mental status or hypotension, that's called the Raynaud's pedant. Acute cholecystitis is most likely the most common complication of having gallstones. Usually patients have persistent epigastric and right upper quadrant pain. They might have temperature or chills and rigors. They can have nausea and vomiting, and very frequently they present with loss of appetite. So, how do patients develop acute cholecystitis? So we have a stone that blocks either the outflow of the gallbladder or the cystic duct. You have increase in the pressure within the gallbladder, which causes edema and inflammation around the gallbladder wall. And effectively, if the blockage remains, then you can have venous ischemia and eventually empyema, which is a pus within the gallbladder, ischemia and necrosis of the gallbladder wall that can lead to perforation, and as we previously discussed, to fistulas with either the common bile duct or the bowel. The most common organisms for acute cholecystitis are Escherichia coli, Klebsiella, and Pseudomonas. However, a lot of other organisms can be the cause, like Clostridium, Staphylococcus, and Salmonella. The diagnosis, usually you see raised inflammatory markers like white blood cells and CRP in regular blood tests. And quite commonly, you can see deranged liver function tests, and also you can easily diagnose it on an ultrasound scan, or if the patient has straight a CT scan or an MRI scan from the A&E, that can give you valuable information. However, the most and the easiest way to diagnose it is the clinical presentation and physical examination. Typically, patients have a positive Murhy sign, which is not exactly right upper quadrant pain or rebound tenderness in the right upper quadrant, but pain that is elicited when you palpate the right costal margin and ask the patient to take a deep breath. As they breathe in, your hand essentially compresses the gallbladder, and that elicits incredible pain to the effect that patients stop breathing. As we discussed, imaging, the best, most likely modality is a simple ultrasound scan. Typically, you can see gallstones, but also a thickening of the gallbladder wall, which is diagnostic, which is easier to see and understand in this abdominal CT scan. You can see the very thickened wall of the gallbladder. You can see the gallstone in the fundus, and also you can see a lot of edema surrounding the gallbladder, which typically the radiologist will describe it as periholocystic edema or fluid. If treated early, that's fine. If, however, the patients present very late, as we discussed, you can get ischemia of the abdominal wall, which can lead to gangrenous cholecystitis. Radiologically, you will typically see gas in the gallbladder wall, which is very easily seen in this abdominal CT scan. And as we said previously, if you have a fistulation of the gallbladder within with the bowels, then you can typically see a big gallstone in the inside the small bowel, and also typically you see a small locule of gas within the right upper quadrant, which is contained essentially within the gallbladder through the fistulation to the bowel. And as you can see on the CT scan, it is very easy to diagnose when you can see a big stone that essentially has blocked the bowel. And again, as you can see, as in the simple film, you can see some gas within the gallbladder. Although we're discussing about gallstone disease, it is important to have an idea that a lot of patients can develop acute cholecystitis without having gallstones. And this can be up to 10% of the cases, and typically patients are critically ill. They are following major surgery. Usually what we see is patients after cardiac surgery, and we quite commonly get called at night from the cardiac ITU about a patient with deranged LFTs, right upper quadrant pain with raising inflammatory markers 2 or 3 days after a bypass, for example. Also, it's quite common in patients with major trauma or burns, and also in patients undergoing chemotherapy. Unfortunately, there is high morbidity and mortality associated with the calculous cholecystitis. So, regarding management, regarding asymptomatic gallstone disease, we tend to reassure patients. We don't offer surgery to asymptomatic patients, but we can always advise them about lifestyle modifications, going on a low-fat diet, or essentially avoiding foods that they feel that they cause them some discomfort. However, there is a high-risk population that could benefit from surgery, even from asymptomatic gallstones. For example, patients, as we discussed, that are due to have heart surgery, are due to have transplantation, or are due to undergo other treatment or chemotherapies. And it's quite common to offer cholecystectomy in these patients during other elective procedures. Regarding symptomatic gallstones, the gold standard is cholecystectomy. In the past, we used to do it open. However, in the last 20 years, most of the cases are performed laparoscopically. For patients that, however, are not fit to undergo surgery, then we have a lot of non-operative managements. We can treat these patients with antibiotics. We can offer them a cholecystostomy, especially in older patients that are very unwell and unfit, which is essentially a drainage of the gallbladder to decompress essentially the system. And it can either be done through the abdominal wall or transhepatic. And in the recent years, the gastroenterologists have managed to decompress the gallbladders effectively endoscopically, with mixed results. However, it is something that has gained popularity over the last couple of years. In the past, we also offered patients lithotripsy. However, the results were very mixed, so this approach has been abandoned. Regarding the NICE guidelines, for the diagnosis, we should offer all patients that have a convincing presentation a diagnostic ultrasound, and if we see on the ultrasound scan that there is a dilated biliary tree, or if the patients have deranged liver function tests, we should offer them more evaluation with either an MRCP or an endoscopic ultrasound scan. We should advise people to avoid food and drink that triggers the symptoms until they have the gallbladder removed. And regarding management, as I discussed earlier, we just reassure asymptomatic patients. We should offer day case laparoscopic cholecystectomy to all symptomatic cases as an elective procedure. We should offer an early laparoscopic cholecystectomy to all patients with acute cholecystitis, ideally within a week. And we should offer a percutaneous cholecystostomy for gallbladder empyema when the conservative management has failed, or when surgery is contraindicated. To summarize, the incidence of gallstones is roughly around 10 to 15% of the population. Most patients are asymptomatic. Most commonly, the gallstones are made out of cholesterol and contain calcium. There are several risk factors. The most common problems due to symptomatic gallstone disease is biliary colic, cholecystitis, pancreatitis, and cholangitis. The symptoms can range from right upper quadrant pain to fever and rigors. The management can be conservative to unfit patients with antibiotic, endoscopy, or cholecystostomy. However, to all fit patients, we should offer elective cholecystectomy. Once again, I would like to thank you. You can assess your knowledge with the questions below, and we would be grateful for your feedback. And although this presentation is available in YouTube, you can always find all our lectures in our dedicated departmental website, which is teachingtuesdays.co.uk. Thank you very much, and we will see you next time.